The views and opinions expressed in the following program are those of the participants and do not necessarily reflect those of KSMQ Public Service Media Incorporated or its assigns.
Tonight on Health Connections, Healthcare Reform Questions and Answers. We're discussing the recently passed Healthcare Reform Bill and what it means for you. Stay tuned, you're watching Health Connections. The recent healthcare reform bill is raising more questions than answers. What does reform mean for residents of our region? What does it mean for people who are 50 years and over? Tonight, our guests are Michelle Kimball, Senior State Director with AARP, and Kenneth Zakin, patient advocate and three-time survivor of cancer. So, Michelle, Ken, welcome to the show.
Thank you.
Thank you.
So, the healthcare reform bill has thrown the entire country into a tussle over the last 30 years, and really a whole lot more over the last year and a half. We finally have passed a bill that has started to move the country in a direction towards healthcare reform. And we're starting to finally see some things happen with that. Here on July the 1st was the first major change of adding taxes to tanning booths. But what are some of the big things that we're looking forward to in the near future? Michelle, what are some of the changes we're going to see between now and maybe 2014 and some very quickly after that?
Well, if you're under age 65, two of the most important changes are access to private insurance in a way you've never had before. For example, you no longer will be denied coverage because of pre-existing conditions. So that is a big deal for lots of people, especially those between the ages of 50 and 64. If you've got a college student or someone who's just graduated from college, you can continue to have your child on your health insurance up until they turn age 26. That's a big deal. And also, insurance companies can no longer charge you more than 3 to 1 simply because you are over the age of 50. In the past, except here in Minnesota, which is always the standard bearer for the rest of the country, insurance companies could charge you 5, 6, 7, 10, 20 times more simply because of your age. It has nothing to do with your health status. So this bill prevents insurance companies from gouging you because you're over the age of 50. So that's a big deal, and that's huge. And also, if you don't have health insurance, you will now, by 2014, be able to purchase that health insurance through health exchanges, which will now be set up in each state throughout the country, and you'll have a variety of choices from which to choose from. If you're low income, you will have lots of extra help to help you pay for that insurance, as well as to pay for co-insurance and deductibles. Over the age of 65, some great changes in Medicare, and the biggest change is a closing of the Medicare prescription drug donut hole by 2020. So that's a big deal. And there are a number of other things around the prescription drug coverage that people will really like quite a bit before that donut hole is closed, starting with a $250 rebate this year, and then next year 50% discount on brand name drugs, 7% discount on generic drugs. So lots of good, exciting changes, and there's of course more, but those are the highlights.
Great, great. So Ken, as a three-time survivor of cancer, as a patient advocate, what do you see changing with this new bill?
Well, some of it was already covered by Michelle, and part of it is, you can't be denied because of a pre-existing condition. I mean, that is just huge. All right. You also could get into, even if you did get in, if you're in the 50 to 64 range, just repeating what Michelle had said about not being able to get into the 5, 10x multiplier on regular premium rates and such. One other big thing that does not so much as a patient, but one of the things that is also key in the Medicare area is that now certain preventive medical checkups will now be covered that weren't before. And this is, I think, a very big thing from a cost reduction aspect, because if you can find things before they blossom, of course, that does lower the cost. The earlier you find it, the less the treatment tends to be.
So one of the things we've heard with the pre-existing conditions is one question that's come along, or a couple of questions I should say, is one is, are all pre-existing conditions going to be classified as pre-existing conditions, such as something like chronic disease of diabetes? Does that still count? Versus something that's more of a nature of cancer or some other long-term disease in that aspect. People have raised a question about obesity, you know, and there's still a question of, is that a disease or is that not a disease? And there's things. Is there any gray area in the bill like that, or
No.
just?
No, it does not matter what your condition is. There are no gray areas, there are no restrictions. Insurance companies cannot deny you coverage, period. If you can pay for this coverage, it is guaranteed issue for you. You cannot be denied because of any condition, whether or not that's an abscess on your toe, or it's cancer, or you're simply overweight. So insurance companies, if you can purchase the coverage, they must issue it to you.
Okay. So, and you raise the other side of that question actually is if they can purchase the coverage. Are there limits on the size of those premiums? Or is there, so say a patient who has a previous condition and may have the possibility of relapse, would you expect to, you would certainly expect to pay more, but is there going to be some huge difference in those premiums?
Well, I know there's no longer a cap on lifetime expenditures.
Okay.
That's one of the key things in there. But I'm not sure I remember anything about regular premiums.
No, they do not cap premiums. They do limit out-of-pocket expenses, which is a great thing.
Yeah.
But they do not limit the premiums. So I think it's sort of a wait and see of what the premiums will be out there. I do know that there is significantly increased competition, which they believe in the marketplace will help keep those premiums low. So I don't see where we will see a huge increase in premiums at all. There may be a slight cost of living bump that people will see, but there is not an anticipation of huge premium increases at this point.
Okay.
And that's what was so key about getting the exchanges in place. And all the rhetoric and everything about the public auction and, the public option and socialized medicine, and without even opening up, you know, that Pandora's box thing again, the exchanges, especially based on a nonprofit model, where you're really eyeing the needs of the customer versus the needs of the shareholder, and looking at healthcare as a right versus a privilege. This is a very key fundamental change in how all this was viewed. It's still a business, but the business option or the business view of it is going to start to change, and that was the big thing. This isn't perfect, but we changed the inertia. The ship, you know, the aircraft carrier, it's not going to turn on a dime, but it has turned. And it's the same thing when Social Security was introduced in the 40s. It wasn't everything it is today, and it was a major event just to even get those initial items in. But once you get the inertia changed, once the compass heading changes, then you have a new vector of which to view it from.
So a lot of people have argued that in the concept of the right versus a privilege and a nonprofit versus profit, a lot of people have argued that if it's a for-profit entity, that they could actually make the costs of healthcare lower versus the nonprofits. Do you think that there's maybe a trade-off there, or do you think there's a better model there?
Well, you can, not to mention names, but there is this rather large institution here in southern Minnesota.
Very large blue.
Very large institution. They are a nonprofit entity, and there's a lot of people there making a very nice living off of that and such. All right, so you know, I don't personally believe, and the numbers that I've seen, I don't really believe that changes it. It changes the mindset, okay, from Are you doing something to maximize, shareholder equity? Or are you doing something to meet the needs of the patient? And in a profit enterprise, and I've spent over 25 years in the for-profit industry, and you always talk about the customer, but if you're a public company, yeah, it's the customer's there, but breathing over your shoulder 4 times a year is the shareholder. And if you're a public company, there are 4 dates in the year. The end date of every quarter when you have to publish earnings. Doesn't happen in a nonprofit.
Michelle, does AARP reflect on that versus a profit versus nonprofit system for our healthcare? Do you think that there's a better focus for the patient, a better focus for companies like AARP?
We really haven't, we don't look at it as for-profit or not for-profit. We look at it as, are people do they have access to the coverage that they desperately need? How will they get that? If you're over 65, that's easy. You've got the Medicare program, and you've got a variety of choices in the Part C of the Medicare program, which is the Medicare Advantage, and you've got not-for-profit and for-profit insurance companies that vie for the Medicare beneficiary. I think that competition is important because that helps keeps those premiums down, whether it's a for-profit or not for-profit. As long as people have the choice, that's what's important, and having the access. And frankly, from our standpoint, it's not this is better than that. It's who is providing the coverage at a reasonable cost, and it's accessible and available to all individuals. And having that choice there is critical, whether you're under age 65 or over age 65. So.
Well, and that 65 is still a huge key number for people. That,
you bet it is. Absolutely.
Moving into Medicare. Now, with the new reform bill, the donut hole closes as Part D, but are things easier for people who are moving into Medicare now? Is it still the Part A, B, C, D, E, F, on and on and on? Is it easier to kind of walk through that now?
No, I think it's more complicated than ever.
Oh, good.
And it's not necessarily because of the healthcare reform bill. I mean, you do have that alphabet soup of Medicare. You have Part A, which is hospital, Part B, which is physician, Part C, which is the private portion, which is Medicare Advantage. And that's giving up Part A and Part B to go with C. And then Part D, of course, is prescription drugs. And within Part D, for example, you have something like 60+ prescription drug plans to choose from here in Minnesota, and it differs from state to state. So you have multiple choices. That gets a little confusing. Here in Minnesota, it's easy because you can go to the Senior Linkage Line, which is run by the Minnesota Board on Aging, and they can really help walk you through to find the best plan that meets your needs. It's the same with Medicare Advantage. There are lots of choices that are available, especially in Minnesota, so that can get a little complicated. But there is help out there for people to sort of sift through those plans to determine what is best for them. And there's lots of things you want to consider, costs and additional benefits and so on and so forth. The one thing that the healthcare reform law did do was it guaranteed your basic Medicare benefit. That's not going to change across the board, whether you're in Part A and B or you're in Part C. So no matter what, your basic Medicare benefit stays the same. It's guaranteed. It's even improved because of now no longer out-of-pocket costs for preventive care benefits. Everyone gets that, and then everyone now gets an annual checkup, which is fantastic. So that, coupled with the new improvements in the Part D benefit, the prescription drug benefit, see some really great changes. There's also a much stronger emphasis on fraud, waste, and abuse, and there are savings in the program that strengthen it and extend the life of the Medicare Trust Fund out 10 years. So it's good for Medicare, all good.
That solvency factor, as you said, it extended the life out another 10 years. That solvency factor has been something that's been just kind of hyped up on both sides of the fence. Both Republicans and Democrats have gone all over on this, and it seems like it's something that's been very difficult to pull out what really is happening here. Is there an issue with solvency that people who are in their 40s have to worry about when they become 65, having something other than Medicare? Or are we still at a point where we've made enough change to the reform bill that that's not really an issue anymore?
It's not really an issue until closer to 2027, in 2026, and then Congress, and it always almost takes a crisis, will start tinkering around the edges again to extend it further. Medicare is not going away. This is a very important program. It will be preserved. It will be extended. It will continue to be strengthened. I think one of the key falsehoods or concerns that people have about Medicare solvency is, and what I'm hearing quite a bit as I travel around the state talking to people about this new law, is how can you possibly strengthen the Medicare program when you're going to, strip out $500 billion from the program? Well, let me tell you that it's not $500 billion that's being taken out tomorrow. We're talking about roughly $35 to $50 billion a year in savings of taxpayer dollars. It's taxpayer dollars that otherwise will not have to be spent over a period of 10 years because of changes that were made to strengthen the program and improve efficiencies and effectiveness. And that amount of savings will be achieved, and so that strengthens the program and extends the life of the trust fund. And I guarantee you Congress will continue to tinker year after year to continue to strengthen it and continue to extend its solvency, for sure.
Well, sometimes that's what we expect Congress to do, just tinker about here and there. So,
yeah, but it's all virtual numbers. It's not like this money was in the proverbial lockbox that we heard over the years. It's all part of the general funds, and it's really just a budget line item in an overall budget. So it's still all part of general funds, but it's just saying, that part of the fund is supposed to be self-sufficient, and okay, it's got another 10 years in it, and then suddenly it goes from black to red as far as an individual budget item, and somebody's got to come up with additional dollars to compensate for that.
Well, the trust fund actually is kind of what we might want to call a lockbox, which I think is what people refer to in Social Security. But the Part A trust fund is what we're talking about as far as solvency, and that is not part of any general fund at all. That is sacred, and it's separate, and that is strictly for Medicare benefits and Medicare beneficiaries. So I think the important thing here is that healthcare reform did help it instead of hurt it, and I think that was the big concern lots of people had was, what are you going to do to my Medicare? You need to protect my Medicare, and Medicare was protected, so that's a good thing.
So if Medicare is solvent and we don't have worries there, then we just have the 64 and under crowd that we have to worry about. So Ken, you're still a young man and still have you're in private insurance at this point?
I'm in private insurance, yes.
So how has it been for you working through private insurance with the conditions that you've had?
Well, as they always said, if you like your current insurance and your physicians, you can keep it, right? And so from that aspect, I'm not foreseeing or expecting any major changes along those lines. I'm not Medicare eligible at this point and such, and we go from there. Hopefully, through some of the changes of additional competition and such, there will be more cost savings and such brought into it. I believe there were provisions in there where they want to start changing the way things are paid for through Medicare and stuff, where you pay for service, not, you pay for results, not for service.
Right. Quality enhancement.
Right, and I always use the old muffler analogy on this, that you go in and you buy, you go into whatever car place and you get a muffler, and they give you a muffler and clamps and a bunch of things, and here's the price, and boom, okay. And 2 weeks later, if something isn't right, you bring it back, they fix it, you don't get charged. But in the medical industry, you go in and whether it's an appendectomy or whatever it is, right, you get a la carted for all the items in there. And if 2 weeks later something isn't right, you go back in, you get to pay for the privilege again. And that just drives a bit of moral hazard in a sense, or moral dilemma into, well, I can just keep do more services and such. So I think that's a very big item, those line items that are in there, as a way of, once again, turning the ship, changing the way the industry looks at it, driving more cost efficiencies, and in the end will drive costs down as well.
And there's kind of a double-edged sword there that has come out, in that on one aspect we're driving providers towards a quality component, but at the same time, then we've got providers who are in effect, quote unquote, firing their patients in some cases so that they don't have to deal with patients who are more complex, so they have a higher quality quotient. Is there an aspect of the bill that still needs to be refined, maybe to bring that along at all, that to maybe take this to the next level? Anything that...
No, I think the components of the bill actually help solve that problem, especially the pay for performance, the pay for quality instead of quantity. I don't think that you're going to see, I think because doctors will be actually getting paid more. I mean, we have that here in Minnesota. Again, Minnesota's leading the country.
Right.
And we have that. It works really well here in Minnesota. We haven't seen doctors firing patients here in Minnesota. Maybe that's happened in the rest of the country, but now this bill is bringing the rest of the country along to Minnesota standards. So I think there are components in the bill that will actually help that, and that's a good thing too.
So with overall quality, do we expect with all these changes in physician compensation to affect quality? There is still this 22% that we hear about in the news that keeps going up and down as far as reimbursement for physicians. Do we think that, or do we see anything in this healthcare reform bill that is going to fix that and maybe finally put an end to that problem?
Well, the problem you're referring to is really the Medicare payment reimbursement problem schedule for physicians, and that is being handled separately from the healthcare reform bill. In fact, it's known, the moniker for it is the doc fix, and that's in separate legislation that is currently working its way through Congress. It's not been completely addressed. It was supposed to have been addressed by July 1st. There's a temporary fix in there, but there's not a permanent fix, and they're working on the permanent fix. I think one thing that the Medicare or the healthcare reform bill does do is it does improve and increase payments for primary care docs and for rural health centers. And that is going to help those aspects of healthcare, but we still have work to do. And if Congress can resolve this separate legislation, then we've got our problem fixed. But if not, there's a big issue that has to be addressed, and Congress still has work to do. Thankfully, it's an election year, so maybe that will push them to get this job done before November.
Or push them to not get it done until November. But
well, then you know what? Voters can hold them accountable, and that's not a bad thing.
I would hope so. Yes.
Absolutely.
So a question from online, from our Twitter community, towards Ken here. As you worked through your experiences in healthcare and working through these different insurance companies, what would have been one thing for you that would have really made your endeavor through everything easier, and something that maybe the healthcare reform bill did address, or something that we have yet to address in healthcare reform, but something that would have made your life easier?
Well, I know there was money set aside within the healthcare provision to deal with medical health records and such, to basically act as a genesis to get that going. I mean, the healthcare industry could learn a lot from normal business in a sense along those lines. There's still a huge aspect regarding complexity. And I talk about especially somebody who's had a hospital stay. And you come out of the hospital after being there for a week or two, you're not exactly 100%, and then what I call the paper tsunami starts. First you get it from the provider. Here's all the services we did for you, and all the codes and the costs, and your head is swimming. And then about a month later you get the explanation of benefits from the insurance company. And they don't line up. And guess who gets caught in the middle is the patient, who, by the way, they're trying to recover. And if it's something minor, okay, but if you're dealing with something serious like cancer or diabetes or other things like that, where it is in a sense a life-changing event, the last thing you have time for is to start battling all these things back and forth. And I believe there's a lot of people who just they can't fight it. They don't have the wherewithal to do it, and they just end up paying the provider what they say they need to pay the provider. Now, I've been able to fight that because, I mean, I've been in the IT industry 20 years, and I know how to get in the web and download things and such. And when I get a call from the provider, you owe this, and I say, no, because you coded it wrong, and when you get it straight with the insurance company, that's fine. Or when the insurance company sent you money later on and you applied it against the wrong item, and all my records are now out of sync with yours, once you get that fixed, then we can talk about resolving these things. But that whole complexity issue about getting standardization with the health records and getting standardization with the billings aspects, that is a huge item that hasn't been addressed yet. And that's the thing, one of the things I believe can make it easier for the patient in dealing with the ramifications of this. You know, the issue in the country isn't health care. We have exceptional capabilities to do health care. It's the administration of it that is really all the problems. And you can see it in the healthcare bill talking about access and preventive care and limits and children up to 26 and people with pre-existing conditions. This has nothing to do with the actual getting health care. This is the application of the health care. And that's still an issue we have yet to resolve.
Well, I think the healthcare debate has been very vigorous up to this point, and definitely going to stay that way for the foreseeable future. We are actually out of time for tonight, but Ken and Michelle, I do thank you very much for coming on the show, and this little half an hour can hopefully help a few people out and see what it is that we're moving into over the next 3 years before we start this new endeavor for this new project. So thank you very much.
Thank you.
Thank you.
Well, this has been Sean Riley on Health Connections. Thank you for watching.